Hi, everybody, and welcome to the Dissociative Identity Disorder discussion or presentation here for the Mental Health Lunch and Learn series. So I just want to mention, I am no expert in this topic, so I don't claim to be having all the answers or all the knowledge about this disorder, and honestly, not many people do. I mean, this is a very controversial and um, ever-changing in the field of psychology, and so our knowledge about it keeps changing, and we don't have all the answers yet about what exactly works and things like that. So this is an ongoing discussion, and there's a lot more to learn. And even the disorder in itself is very controversial. That some people don't believe that it exists, and um, so there's a lot to cover, and this could be a whole course in itself. But so this is going to be an introductory presentation on the disorder. Okay, so we're going to be covering just defining DID, its terminology when we're discussing it, and for the people that have it, the terms that they use to refer to all of their parts and things like that. We're also going to be talking about etiology, or where it comes from, like how it develops. We're going to be talking about treatments, as well as the intersection of DID and adults with intellectual and developmental disabilities, which is the population that we support. So the intersection of those two is a little more rare, and honestly, not enough research has been, covering the disabilities population as a whole, but especially with dissociative identity disorder as well. So still trying to figure out what the best course of action is there, but in general, people with DID and IDD are generally supported in the best ways we know how, except that may be changing over time as more information is retrieved or sought out. And then we're going to do a quick summary. We'll have a couple of videos in here too, just to show kind of what the experience is like, and then actually seeing somebody switch, because I think that's the most interesting part for the most part that people think of when they think of DID. They want to see the switch happen between the different identities, and so hopefully you'll get a sense of what that is like. Okay, so first off of all, what is DID? So it has in the past been called multiple personalities disorder, but it has always been characterized as a dissociative disorder, not a personality disorder, because the disorder itself is when there are different personality states. So the person dissociates from the person that they are into another identity. So that is a dissociative disorder, not personality issue. And this happens because it's a psychobiological response to trauma suffered in a specific window during childhood. So it's believed that the earlier it happens in childhood, between the ages of like 4 to 10, I believe, is what the most crucial point where this disorder can develop. And as you can imagine, the sooner that this trauma happens in childhood, the more that the development of that child is kind of stalled and interrupted, really. And so this is a very complex post-traumatic stress syndrome, and we know that trauma physically affects the brain, and it does so in DID as well. As you can imagine, they are related. And so if trauma affects the brain, obviously we're going to see that in DID as well. So the diagnostic criteria to be diagnosed with DID includes a disruption of identity characterized by 2 or more distinct personality states, which can be described in some cultures as possession, where the person seems to be physically taken over by another person, and their body and mind, everything. So that's kind of what it's related to in some cultures and believed to be. However, when this happens, these personality states take over, it is a disruption in identity. And um, you can see that there's a discontinuity in sense of self, who the person is, and their sense of agency, like how they express themselves. um by change, also we see changes in affects, like their facial features, their emotions, their behavior, their consciousness, whether they're aware of what's happening, and their ability to remember the past and what is even going on in the present moment, their perception of their environment around them, their ability to think about and process what is happening, and then their sensory and motor functioning as well. So that's again, it's a very, very complex disorder, and the ways that it can manifest are going to look different for every person. And because of all the different ways that it can be expressed or manifested, you can only imagine how the person experiencing it would feel, and all the different personalities that could come out in a person or develop when there's so many different ways that it can look like. And then to be diagnosed, you also have to have recurrent gaps in the recall of everyday events, important personal information, and or traumatic events that are inconsistent with ordinary forgetting. So basically, people with DID often have periods of time that they can't remember. And this can be even, going to the grocery store or something like that. Maybe they'll dissociate, and one of the alters will come out, and they will all of a sudden kind of come back to the original person and not really remember where they have been for the past hour. So that can definitely be a scary experience. And as we'll talk about a little later, we all dissociate to an extent, but the level of dissociation with people with DID is much more extreme, and it causes a lot more dysfunction. Um, so these traumatic events, we'll talk more about like what exactly that means and what that can look like. But um, the person the person with DID may not even remember that trauma has happened, because of all these other alters that have been formed as a coping mechanism to physically, remove that traumatic experience from their memory altogether. So obviously, these gaps in memory and recall are very different from just ordinary forgetting, like where you left your keys, for example. So it's just very, very different from everyday ordinary forgetting that we may experience. And then all of these symptoms must kind of create clinically significant distress and or functional impairment. So that means that the person isn't able to function in their day-to-day life, and they're not able to complete a lot of the activities or that they want to or need to. So it can be very, very disruptive in their life. Okay, so signs and symptoms that someone may have DID is, again, that memory loss, depersonalization, and derealization. We'll talk a little bit more about each of those and distinguishing them, but depersonalization is basically the person kind of feels detached from their body, and they feel like they may kind of float out of it and like be looking at themselves, looking from outside of themselves, if that makes sense. And then derealization is when the person feels as though their environment is not real. So like they are fully integrated into themselves, but they're looking around them and saying, I don't know if, this may be a simulation, like this doesn't feel real to me. The distortions are obviously having kind of a warped sense of reality, or what's going on around them. The person may engage in behaviors that are out of character for them. So maybe the person with DID is very shy, very meek and mild, and not very adventurous, but maybe they're going clubbing every night, where that is not a typical behavior for them. The person may also experience hallucinations, where they may see and experience things that may or may not be real to them or to the person without DID. They may also have sleep disturbances, not being able to sleep at night, maybe waking up more frequently, trouble falling asleep, things like that. Because again, when you think about it, the person with DID has all of these different personalities within themselves, and so if there's a lot of there's not a lot of integration between them, or there's a lot of communication. Um, we'll definitely talk more about this, but they can communicate with one another. So a lot of times, maybe the host or person with DID is ready to go to sleep, but the other alters are, wanting to come out or having an issue with something. So, and it sounds very, very abstract, and it is, but as you can imagine, this can be very disruptive, and again, impair the functioning for that person. It can also be sexual dysfunction, headaches. We'll talk more about that, but there can definitely be headaches that the person experiences when a switch between their personalities is happening. Um, and this can look very, very different when switching can look very different. So we'll talk more about that as well. But um, there can also be a lot of life challenges like unstable relationships, inability to keep a job, or not being able to keep up with schoolwork and things like that. And then another thing, which we'll talk more about, this is not always present, but someone with DID may talk to themselves. Because again, these alters all communicate differently, but maybe this can look like the person talking to themselves, but in reality, they're really communicating with one of their alters or alternate personalities. Okay, so dissociative disorders as a whole involve problems with memory, identity, emotion, perception, behavior, and sense of self. And these symptoms generally, can disrupt every area of mental functioning. So it can affect how you process and regulate your emotions. It can affect how your brain processes information and how you respond to threats, things like that. And even just your ability to be present and focus on a task can really be interrupted and altered by these kinds of disorders. So in addition to DID, there are two other dissociative disorders, which are dissociative amnesia and depersonalization slash derealization disorder. So dissociative amnesia is the inability to recall information about oneself, which is not normal forgetting. And this is usually related to a traumatic or stressful event, as we've mentioned before. So this does not include the formation of any other alters or personalities. This is just, having periods of amnesia where you don't remember things, but that doesn't include the formation of the other personalities. And then depersonalization, as I mentioned before, is when there's a detachment from a person's mind, self, or body. They may kind of feel like they're outside of their bodies, watching events happen to them, and not really feeling as though it's happening to them in their body, if that makes sense. And then derealization is when you're detached from your surroundings. So you may feel like the things or people around you are not in fact real. And then there are 5 core components of dissociative disorders. So as we mentioned before, amnesia, derealization, depersonalization, identity alteration, and identity confusion. So identity alteration can include having a loose sense of identity and kind of feeling as though you may be mostly yourself, but also somebody else. Or you may kind of feel like someone else altogether. And then identity confusion, you may just kind of, again, having that confused sense of identity of who you really are, and if you are being who you really are in each moment. Okay, so we have to talk about what DID is not, because this is a very, very controversial disorder, and a lot of like misinformation has been put out there. So just want to kind of address some of those and then clarify what it is. So first off, it's not a personality disorder. It's a dissociative identity disorder, like we talked about before. So it's not a personality disorder like bipolar disorder or borderline personality disorder. This is about dissociation from the person themselves. And then related, that this disorder doesn't always mean that the person needs to be in a psych ward or anything like that. Like, while it can create a severe amount of dysfunction in a person's life, it doesn't always mean that they can't function. So there are many, many people out there with DID that actually live full lives and have families and full-time jobs, just like anybody else. So that is definitely another misconception. And then DID is also not a fashion statement. It's not an alter ego that the person willingly creates. It's not like, Nicki Minaj's Roman character that she has, or Sasha Fierce like, for Beyonce. Honestly, I don't know Jennifer Lopez's name there, but the point is, this is not something that people willingly do just because they want to. This is a trauma response. And so we got to be, realistic about these things and where they actually come from, and not like assuming blame or thinking that somebody's doing it for attention, because that is very much not the case. And then D&D is also not a scapegoat. I know that was a very cute photo of a sheep. It's supposed to be a goat, but I like that all the fingers were pointing at this sheep or goat, whatever you want to call it, because a lot of people have assumed that people are using DID to kind of get out of life's problems, or they're using it as an excuse and things like that. Similarly to the bad cat we have over there. Some people use DID as an excuse to get out of crimes and things like that, when in reality, someone with DID may actually be in that situation. But again, it's not an excuse to be used whenever someone is caught doing something wrong. And then also, DID is not schizophrenia. So there is some confusion, because they both may experience hallucinations and hear voices. And there has been the term split mind used in schizophrenia, which has been kind of confused with DID. But basically, in schizophrenia, split mind refers to when somebody is kind of splitting, or like having, like switching between reality and fiction. So someone with schizophrenia may have trouble being present in the moment, and they may be having these hallucinations. And so split mind is really what it means to kind of fluctuate between reality and fiction. So while there is maybe a similar experience with people with DID, it doesn't mean that they're fluctuating between reality and fiction. It's more so these alternate personalities coming out. Although they can both experience hallucinations and hearing voices. But again, with schizophrenia, the voices are usually telling someone to do something something violent, or things like that. But that's not always the case for people with DID. A lot of times it's the different fully formed humans with their own complex identities wanting to communicate with the host, and they all serve a specific role. But we'll talk more about that. But very different from schizophrenia. And then hopefully parents will take comfort in knowing that just because your child has an imaginary friend doesn't mean that the person or the child has DID. So it's a very common experience in children, but that doesn't mean that they're going to go on to develop DID. Okay, so some facts of DID. As we mentioned before, it was previously called multiple personality disorder, but it's always been classified as a dissociative disorder, not personality. And only around 6% of people with DID show signs of their diagnosis on an ongoing basis. So that basically means of all the people with DID, only 6% of people are able to be identified as having DID externally on an ongoing basis. So, related to the next point, prevalence is controversial and uncertain about um, how common this disorder is, but it's presumed to be between 1 to 3% of the population. But again, if only 6% of the people with DID are showing signs where it's kind of noticeable, not all people with DID are going to seek treatment. So that number is likely higher. So the highest recorded number of personalities is in the hundreds, and honestly, I think I've even seen in the thousands, although the average is about 10 personalities within a person. And the average used to be between 2 and 3. So you can see how this is kind of morphing over time and growing and increasing as we get more knowledge and we have more studies about this. But um, as time does go on in the person's life, with DID, they can develop more personalities as they develop, as they grow, as they age, as they encounter new situations, or maybe even repeated trauma. Different types of trauma different can cause different personalities to emerge. And then, of course, DID differs from person to person. So they may have communication between their different personalities. They may not. They may know about each other. They may not entirely. Um, so again, every person's experience is different, just like every person's unique human experience is different. Okay, so terms used in DID, the world of DID, and just people that have it themselves. Um, so when we're talking about the person who has DID, like the original person that was born that develops these alters is called the host. So the host is generally the person that spends the majority of time out, meaning the person that is experiencing the world, and like they are truly like fully themselves. And this is who the alters branch out from. And then the alters or parts, the terms are kind of interchangeable, but alters, parts, personalities, identities, these are all kind of words to describe these personality states that are formed from the host. And they all operate independently. They perceive themselves and the world in their own unique way. And they have either the capacity to assume control of the mind and body of the host, or they're able to kind of influence the host enough to impact their thoughts, feelings, and behaviors of the host or of a presenting alter. So as we'll see in a video, many alters can be kind of communicating at once. They can be kind of flooding the internal mind of the host, and so, or the presenting alter. So whoever is out may be also hearing the communication from another alter trying to tell them what to do, or what they want, or things like that. So it can be very disorienting, as you can imagine. Amnesia, we've already talked about, just having those gaps in memory. Dissociation is a disruption in a person's sense of who they are, their memory of the past, and their ongoing experiences. And then a system is, that's the term that people use to refer to all parts of the person as a single unit. So when we refer to somebody with DID, we call them a system. That includes the host and the alters. And this is also how people with DID refer to themselves most commonly, or other people with DID. They'll say like, oh yeah, like I know this system that has, 40 personalities or 40 alters, things like that. So it's just a general way to refer to all of the people within the person. And then co-consciousness is a very important term. So this means if someone with DID is co-conscious, it means that all of the alters are aware of each other and they're able to communicate. And using the reference of a person in a car, so say one alter is out driving the car, meaning they're controlling, where the person goes physically. They're taking different routes and things like that. And then all the other alters will kind of be in the car with them, but able to see each other and able to communicate. So that's kind of a good way to think about what this looks like to be co-conscious. So this means many alters are able to be aware and remember what's happening. They're kind of all present together, even if they're not fully out or like showing externally. Okay, so we're talking about here the common ways that we dissociate versus problematic dissociation. So we all dissociate every day, and this can look like daydreaming or fantasizing, driving. We may kind of go on autopilot and kind of have a scary realization like, oh, I don't know how long I've been dissociating for. Um, but again, your body kind of goes on autopilot and hopefully, nothing dangerous happens. But this also happens when we're reading. We kind of block out the world around us and really hyper focus and kind of we integrate ourselves fully into like whatever story we may be reading about, for example. So obviously, in the everyday dissociating that happens that we all experience, this is where we're more integrated. We have more control about like how long we're fantasizing, how long we're, daydreaming and things like that. We're able to come back to the present moment when we want to. Whereas on the other side of the spectrum, where there's PTSD and dissociative disorders and DID, which is more problematic, there's a lot more dissociation happening for longer periods of time with less control and to come back to the present moment. And it's much more, it causes more dysfunction in the person's life. Okay, so alters. This is definitely one of the most interesting aspects of this disorder. So alters can take on a variety of characteristics, roles, genders, personality traits, medical diagnoses, and psychological diagnoses. So this is very, very complex and as you can imagine, this can look so many different ways. And so, for example, what this can look like is, say the host is a 25-year-old female, and then she may have alters that could be a 4-year-old boy with an anxiety disorder, for example. It could also look like having a 30-year-old heterosexual male with high blood pressure. It can look any number of ways. And a lot of times, it doesn't just mean the person has like one characteristic or two. It means like they're a fully formed human with, with personality traits and opinions and preferences, different diagnoses. It's like all of these things at once for each alter. So every alter is drastically different. And when one alter is coming forward, it generally takes place of the host. And this can often, but not always, lead to amnesia or memory loss, which is one of the most prevalent effects of DID. So, as you can kind of imagine, when an alter is taking over, the host is not emotionally present. So that would kind of make sense of why they might not be able to remember everything. And the alters may or may not be aware of one another and be able to communicate. So this kind of looks different for everybody, but generally, the longer periods of time that have gone on where alters have been amongst each other, and the more that they're able to communicate, the more that they're more likely to integrate and be able to coexist peacefully and prevent the dysfunction in the person that has DID. But again, this can be very, very drastically different. So communication between alters, they can communicate internally or externally with one another, which can be very disorienting, as we're going to see in a video on the next slide. So as we mentioned before, the alters may talk aloud to themselves when really that's how they're talking to alters, or they can use their thoughts to kind of communicate with one another internally as well. So you can imagine a person at the grocery store or just walking down the street or trying to have a conversation with somebody and maybe having alters communicating in their mind with one another while the presenting alter or host is trying to talk to somebody in front of them. So it can definitely be disorienting. And then regarding how they emerge, it can be random, but it's most often due to triggers, which can be, maybe one alter really likes gardening or something like that, and the presenting person or the host is gardening, so maybe that alter will come out while they're doing that activity that that alter enjoys, or dislikes or threats. So threats are most common to trigger an alter to emerge because all of these alters are protecting the host. They form, of the all of them are created to protect the host because of something traumatic. So again, some of them are going to be coming out when the person feels threatened, and it is quite common for there to be a child alter and a protector alter. So, using the example before, the 25-year-old host, female host, she may have a 4-year-old female child, which is kind of like her younger self. And it's kind of like, maybe 4 years old is when that host experienced trauma for the first time, and the child alter is kind of frozen in time and may kind of come out when the host is doing more childlike activities. And then maybe during times of threat where the host feels threatened, maybe there's a 40-year-old very muscular male alter that comes out to really protect the host physically. And again, these alters can have different levels of strength. They can have um, different dialects or even different accents, all kinds of different things. So they all play a certain function and they come out at different times. And it may or may not be noticeable. Actually, we'll get to that a little bit later, but this next video is going to kind of show you what it can look like internally. And again, this is very dramatized and, may not be everyone's experience with DID, but this is kind of what it can look like internally for the person.
On your feet. Doctor wants to see you.
Without a name, you can't know.
It's the game.
Heather, Thomas, Harris, Joey, and Bo. For weeks now, we've been talking. You've introduced me to a lot of different people, each with a different name. So my question is, who am I speaking to now? Next week, you're up for evaluation. If it goes well, you'll qualify for a supervised release program, and eventually.
I'm so sorry, Doctor. I did horrible things.
No, deny everything, confess nothing.
You want to change. The only way you can get better is if you
work for the government. You're inside my head. You can read my thoughts.
I'm being held here against my will.
You're here because the alternate selves inside your head have taken control.
Are you really?
Then tell me,
John Jacob, that's my name.
start with
That's my name.
but I can't do that if you won't listen. The only way you're getting out of here is if we work together. Now, you were going to say something. Go ahead. Good to have you back, Daniel. It's been a long time. Now we can get back to
Okay, so as you can see in this video, there are drastically different personalities involved in this person with DID, and they do use the term multiple personality disorder, but really they're talking about DID. But as you can see, a lot of the time, like they can be arguing, they can be telling the person what to do, they can be trying to come out at different times. Now, there was a significant amount of switching that this person experienced in a short period of time, so that may not be common, and they may not kind of be able to just come out whenever they want to. But in a stressful situation where someone may be in a prison or something like that, that may be triggering enough for a number of those alters to come out. But one thing to note is the way that this doctor woman, the way that she kind of yelled at the person to try to quiet all the alters. That is, I mean, I can't speak to that, of course, but I do not believe that that is very realistic, and being able to make them all go away, because they don't ever really go away, but they just hopefully become more cooperative, and the whole system can work together as a unit, as opposed to trying to fight for fight for the attention, or fight to come out in certain situations and things like that. Because often if you yell at a person with DID, that's gonna make them feel threatened, and that can make that protector alter come out. So again, I definitely don't recommend yelling at somebody with DID just because you want them to focus on a conversation you're having. That is something that the host kind of needs to work on in their own treatment, to be able to communicate effectively and ensure that all the different alters kind of get what they need, so that they don't forcefully kind of come out in situations when the host doesn't want to. Okay, so there are different types of switching between alters. So there's a co-consciousness, like we talked about, where they're all aware of each other. They're kind of both. They're all in the car together. They're aware of what's happening. They know what's going on. They're able to remember, and they're kind of all present together. And then there's consciousness, but without the ability to see and hear what's happening. So maybe the person is going to an amusement park, and the other alters are kind of aware of that, but like they're aware of each other, but they're not able to kind of see what the person is physically doing at the amusement park, and they're not able to really recall what's going on. And then there's this type of switching where there's total unawareness, where the host, has no idea, why there's a 3-hour gap in their memory, and they don't know how they got to where they are. They're not even aware that they have alters. So that can all look different. And what does switching feel like is one of the frequently asked questions. So from what people with DID have explained, it can feel like brain fogginess, dizziness or lightheadedness, cold sensations, more commonly feelings of detachment, so kind of feeling like you're not fully yourself. You may be feeling partially yourself, but maybe also someone else. And then you may be hearing more loud internal thoughts that are not your own. So that's how a person may kind of be alarmed to the fact that they may be switching. And then, is it noticeable? It depends. It really depends because, when you think about it, if you're sitting on the couch and an alter comes out that is very similar in age and mannerisms and personality to the host, it's not going to be that noticeable. But if you're walking down the street, the host is walking down the street, and then they start getting robbed or something, that could cause a drastically different alter with a different set of skills and the role that it plays, and different like different muscle mass, all of that kind of thing. So again, it depends on the situation in which alter is coming out and when. So it depends, but switching can happen in seconds, minutes, or hours. And from what people with DID have explained, when a switch is taking longer, that's typically when they tend to have headaches. And they may try to kind of encourage the switch to happen to try to get that headache to stop. And then the switching can last minutes, hours, weeks, or even months. So depending on the situation, the alter can be out or in control for a very, very long period of time, or it can just last from one situation to the next or something like that. But it's going to be very drastically different. Okay, so this next video is going to be of this woman. I believe she has claimed to have 2,500 personalities. So I cannot even imagine or fathom what that's like, but or how you quantify all of them and distinguish them. But anyway, this is a woman from Australia that is seemingly able to kind of invite her alters to express themselves and to come out. But this is not a very common experience. So I just want to note that, like, not everybody is able to kind of call on their alters and encourage them to come out and kind of take over. But switching is definitely the thing that most people want to kind of see. They want to see those facial features change. They want to see a switch happen. And so this is a video showing that. But again, this is not the most realistic and not very common either.
ED. Well, we prefer multiple personality disorder. We understand that some people prefer the term dissociated identities, but mine aren't dissociated. It's not like we woke up and said, oh, I have to do something unpleasant. This is my job. I don't want to own that, so I'll push it away. That's not part of me. That's not how we worked. I was born and then I was removed by Symphony. And after that, and I shall ask her to come out and tell you this, because after this, it all gets a bit blurry for me.
Sure.
I'm Symphony.
Hi, Symphony. Symphony, you're 4.
Yes, 4 going on 50. I've got to be 4 because I'm hoping that when I get to testify, that I can grow because I've got to stay this age because I've got to tell about Daddy.
You are in charge of those facts.
Yes.
You know what happened.
Everything that he did after I took Jennifer away, he did to me. So every single bit of abuse I have experienced, that's my job. My job is to deal with Daddy.
That job was a big job.
It was enormous. The first person I created after me was a man called Eric, and Eric is our organizer. So as people were created, Eric made them an internal landscape where they live, and he gave them their list of rules, and because everybody's got rules.
There are some very strong personalities in there. Some people
Yes.
who are with you
All the time, yeah.
all the time. Tell me about them. Let's go through some of those.
Okay, let's start with Muscles.
Let's.
I love Muscles. Actually, I will ask him to come and talk to you, if that's okay.
Yes, of course.
Oh, okay. Hello.
Hi, Muscles.
Hi.
Muscles, you take on a whole demeanor, don't you? You've
If
arrived.
you're going to be here, you're going to be all the way here. There's no point being a half-ass. Just be here. Yeah.
Your role is protection.
Yeah, my role is complete protection. I'm not the kind that sits back and goes, "Oh, you know, all will be fine." I'm much more of a get up and do it kind of a guy, and I wanted revenge.
Who are the others in your repertoire of friends, your personalities who are important to how you function?
Oh, Volcano, leather god extraordinaire. I want to see him walking around in his leathers.
And what does Volcano do?
Volcano does not do what you think he's doing. So everybody goes, Volcano, that sounds dangerous. He is a total sweetheart. His job is to tell you, you are allowed to feel what you're feeling. What you feel is absolutely appropriate. He has a sense of what normal is.
Who else are strong, important?
Judas. Judas has been trying to tell. Actually, he is sitting in the background, agitating. You're telling, that's my job. My job. He's 7 going on 8, and Judas does exactly what his name says. He is Blab. He will go and tell you anything.
Now that you know this war is over, are you not able to become one, Jenny?
No, because it came out of the back of my head. I don't know how to put them back in. You see, everybody thinks that Jenny has alters.
Right.
I don't understand. Jenny's an alter.
Yes.
She's just as much as an alter as Eric or Muscles or Linda is.
So you can't become Jennifer?
Oh gosh, no.
That's
No.
done.
Yeah, that's yeah, I can't do that.
But
Jenny,
you will always be Jenny.
I will always be Symphony.
You will always be Symphony.
Yes.
Okay, so this video is very interesting for a number of reasons. So first, if you'll remember, she talks about how when she was 4, the altar of Symphony was created because of the abuse that was happening from her father. And so she mentioned that she is 4. That altar is age 4. And she mentioned hoping that after, I guess, going to trial and speaking and testifying, that after that experience, kind of having that resolution of that trauma would allow that 4-year-old symphony to be able to age. I don't know for sure that aging really happens in these different altars. I know that they can have birthdays and things like that, but I don't know for sure that aging is a typical experience, or if the person certain altars are frozen in time or others aren't. I don't know that for sure. Um, but it's very interesting. And she mentioned that the host, Jennifer, was kind of removed because of the severity of the trauma that she experienced. So some hosts are may be gone forever and they'll just kind of alternate between these altars for the rest of their lives. Or it maybe the trauma was obviously severe, but maybe it wasn't severe to the point where the host couldn't even, be a little bit of themselves anymore. Um, because again, these altars are protection. They're offering that protection to the host, and if they feel like the best thing for the person is to fully take over forever, then that's something that can happen. Um, Another thing is just nobody, at least from what I've seen, it's not common that people can kind of call on their altars to switch like that on command, and especially in front of a camera or a crew and things like that. So um, again, it's been tough to record this type of experience because not all the altars would allow that to happen because they don't want to be exposed. They don't want, maybe they see it as a threat. So honestly, this experience that we just saw could be very potentially dangerous depending on the altars that exist within the person, and like what roles that they play. So this could look drastically different for each person if they tried this. Okay, so where does DID come from? So it's caused by overwhelming and repeated experience of traumatic events or abuse in childhood. So abuse can look a number of different ways. It can include neglect, like having a child's basic needs not met, or safety, failure to respond to a child and give them that comfort or protect them, or just give them food and water, for example, or just not responding when the child is crying can be very traumatic for babies. But we're talking about like failure to respond for like long periods of time. um, and then also medical trauma. This can look like repeated surgeries or exploratory procedures, things like that. That can be very traumatic to children at a young age. And DID and the experience of going through this trauma really prevents the child from forming a unified sense of self, and having an identity of their own. So instead, they kind of create these different alters as a coping mechanism. So they'll kind of dissociate from the trauma to say like, oh no, like that trauma happened to Jennifer. It didn't happen to Eric, for example. Using that video that we just saw. So those alters are protecting the child psychologically by keeping trauma memories and emotions contained within those specific identities so that they don't overwhelm the child or the host, even when they're an adult person. So comorbidity it means kind of like disorders or conditions that may coincide or go along with DID that are common. Can be headaches, like those switch headaches that we talked about. Can be depression, anxiety. Again, because of the history of trauma, that can very well manifest in the form of depression or having anxiety. Substance abuse can be a way that the host maybe tries to quiet or numb or dull down the communication that they may be hearing from the other alters. And then it may also coincide with eating disorders, obviously PTSD, and then also personality disorders like bipolar disorder or borderline personality disorder. So oftentimes a person with DID may be diagnosed with a whole slew of things before they're really diagnosed with DID. So oftentimes people with DID have a lot of these other disorders because they either truly do exhibit them, or some of their alters do, which is even more fascinating and complicated. Okay, so DID in the brain. So there are a number of mixed findings on this, but most studies, when compared to the brains of control groups used in studies, DID patients showed smaller cortical and subcortical volumes in the hippocampus, which is involved in memory recall, um, and the amygdala, which is the fear and emotional response center, parietal structures involved in perception and personal awareness, and frontal structures involved in movement, execution, and fear learning. So basically, if they have smaller volumes in all of these different brain area regions and structures, that means that they're not going to be functioning properly. And so, moving on to the next study, and from 2014, the volume of the hippocampus, which again is involved in memory and recall, it was measured in females with DID, and they found that the more severe the trauma, the smaller the hippocampus. And in this figure, in this slide here, it was also found that structure, the amygdala structure, which involves the fear response and regulation of emotions and fear response, um, they found that it, it was very much smaller in females who had DID, as well as hippocampus, as we mentioned, involved in memory. So that means that because that structure is smaller, it's not going to function to the full capacity that it should, and it may kind of misinterpret the stimuli that it's receiving. So people with DID may have an amygdala that's hyperactive because their brains are kind of wired to be more um, to pay more attention to threatening stimuli in their environment. But this is not always doesn't always mean that the stimuli is a threat. So their amygdala is kind of on guard and just really trying to respond with fear in situations that it doesn't always call for that. So that can be very disruptive and cause a lot of distress for the person. And then because the hippocampus is smaller, they're not going to have the same memory capacity and ability to recall memories that a person without DID would have or would be able to. And then studies have also shown that in the brains of people with DID, there is a decreased blood flow in parts of the prefrontal cortex, which is involved in like executive functioning, making decisions, things like that, which is similar to people with attention deficit disorders. Again, this could be a whole course in itself, but this is just a very basic information. Okay, so treatments for DID include EMDR, which is eye movement desensitization and reprocessing. So this is where a person tries to recall and reprocess the trauma that they've been through while doing rapid eye movements. This is intended to kind of desensitize the person to the trauma and process it in a safer and more effective way to allow them to function a little bit better than they have previously. And then hypnosis is also a form of treatment that has been sought out for people with DID to try to kind of communicate with the alters and try to heal those parts of them that are wounded and hurting because of the trauma. So it can be a way of trying to get all the parts to be cohesive and for there to be harmony between them and also heal the trauma in itself. But psychotherapy is generally the most common form of treatment where you're working directly with the alters using cognitive behavioral therapy or dialectical behavioral therapy. And you would assume that in psychotherapy you're trying to process that trauma like you are in EMDR, but it was found that really, experts in treating DID spend more time on techniques for containing the trauma rather than uncovering it, because the host and all the alters are kind of constantly aware of that trauma. They know a lot of times like what happened, they don't want to reprocess it, and it can be dangerous to try to do that. So instead, in psychotherapy, it's more common for there to be a focus on grounding and safety interventions, just to try to orient the person back to the present moment and make sure that they are safe. And then medication is not a form of treatment to use for DID because, um, again, it's a a dissociative disorder. It's not a personality disorder that is more commonly treated with medication. Um, and it can be dangerous to try to treat somebody with DID with medication because not all the alters may agree to take medication, or one alter may try to overdose. So you can imagine the kind of complexity to treating somebody with something as simple as medication that we may take every day and not really think much about it. And then another aspect of medication in treating DID is, again, we mentioned before, or I mentioned before, person with DID has typically a lot of comorbid disorders. Um, they have a lot of different diagnoses, a lot of different like diagnoses and mental health diagnoses. I mean, and then so the medication is really to treat those comorbid disorders. It's not to treat DID. So maybe the person with DID has depression, so the medication that they're most likely to be on is, for example, an antidepressant to address the depression, not DID. So treatment goals for people with DID is really going to focus on, ideally, the ideal but kind of unrealistic goal is for there to be fusion, which is permanent merging of all the alters. However, this is not always possible, and it's also not necessary for healing. So the more realistic outcomes is really resolution or functional multiplicity, where there's harmony between the alter identities and they can coexist without impairing the functioning of the host. Okay, so there are different treatment routes and phases here, so I'm going to go over these quickly. But the first phase of treatment is really establishing safety, stabilization, and symptom reduction. And then phase two is where you're confronting, working through, and integrating traumatic memories, returning to phase one for that safety and stabilization when you need to. And then phase three is integration and rehabilitation. So the goal is for there to be some fusion of the parts to go all together where there's no sense of separateness between them. They all function in a cooperative and coordinated way. Okay, so DID and IDD. So again, there's not a ton of research out there, unfortunately, on the intersection of these two, but generally, there has been found that like when there's an intellectual disability or developmental disability present, DID can go undiagnosed or be misdiagnosed as the intellectual or developmental disability. So, for example, if someone has been seen to be talking to themselves, they may assume like, oh, that's because they have an intellectual disability. They may not always think that, like, oh, maybe, oh, of course, like they may be able to have both a disability as well as dissociative identity disorder. So when supporting someone with both DID and IDD, you want to really, really just focus on educating yourself about both diagnoses, specifically about where DID comes from. And, as I've mentioned a lot, every person's experience is different. So you'll want to really try to understand like where the person is coming from and what their experience is like. So see if they would be open to sharing that experience with you after building a strong relationship built on trust and safety. And then it'll be important to learn the hosts and the alters triggers as well as likes and dislikes, because that'll give you a lot of information about when they're likely to come out and how to ensure that the person is safe. And as as it mentions here, you got to create a safe, calm environment to try to prevent those negative triggers to avoid some of those stronger personality alters from coming out. And then, if possible, work together on creating a safety plan and how to support each alter. And as that one video showed, don't shout at the person and tell an alter to leave, because one, that's not really possible for them to fully leave, and second, you may just trigger them further and create a dangerous situation for yourself and the person with DID. And then it's really crucial for there to be a significant amount of communication, coordination, and education from the person's mental health treatment providers to fully understand what it means for this person specifically to have DID and an intellectual disability, and just how to support them. Because again, it's going to differ. So we've got to learn what each person needs. Okay, so a summary. DID develops as a coping mechanism to ongoing repeated trauma. DID is a psychiatric condition that has been controversial for years, and knowledge about this disorder continues to develop over time. We do not know everything now, and we probably never will, just because of the drastically different and complex ways that it can be for every person with it. And then every person's experience is different, as I've said so many times, but I'll just keep saying it. It's kind of similar to, a person with autism. You meet one person with autism, you've met one person with autism. So it's similar for people with DID. And then treatments vary, but the focus is on integrating all alters to coexist in harmony to allow the host to function properly. Okay, so again, this is a very, very complex disorder, and this is not all the information you can know about it. So if you're interested in learning more, I encourage you all to do your own research, and just, being aware of the signs and symptoms, and just in case that is ever applicable to the people that you support, so that we can make sure that people intervene early or as soon as possible, and try to just encourage the best treatment and functionality in a person's life. All right, thank you so much.